Welcome to the presentation for Nursing 150. This presentation is going to cover osteoporosis and Paget's disease in relationship to the care of the patient with activity needs. Concepts related to the care of the patient with activity needs associated with osteoporosis and Paget's disease. The concepts include difficulty with mobility. And when we talk about concepts, we're talking about the concepts that the nurse needs to understand and identify with, because basically it's the patient's needs. So a patient with osteoporosis or Paget's disease will have needs related to their mobility. They will have pain issues. So the nursing care will be focused on assisting with mobility and assisting with making sure their pain is under control so that they can be mobile. Sensory perceptions means that there can be some numbness, some burning, tingling in their extremities. So again, those are the things that the nurse needs to think about as far as care of the patient with these disease processes. And that's what we're going to apply to the knowledge that we learned about osteoporosis and Paget's disease. So begin to think about how a nurse should take care of a patient who would have difficulty in mobility. It's things like safety, making sure they have a safe and effective care environment, promote health, helping them with their mobility. Think about health promotion, identify things that can help them maintain their mobility. Other things to think about is just assessing their pain, making sure that it's treated well, that you're making sure that they're not having any side effects of their pain medication, and that it's actually effective and that it's not interfering with their daily life. It's important to review the assessment of the musculoskeletal system when we talk about activity needs in a patient. Think about how we assess whether they have proper range of motion of their extremities, if they have pain with range of motion. Think about the effects of aging on the musculoskeletal system. Musculoskeletal system is the second largest body system. We're talking about bones, joints, skeletal muscles, as well as the supporting structures to move them. We're talking about tendons and all the things in the musculoskeletal system that support it. For this presentation, it's important to review the bone, because these two diseases are metabolic diseases of the bone. So review your anatomy and physiology about the different types of bones, and think about how the bone is a dynamic tissue. The bone has a continuous process of formation and something called resorption. Resorption is the process of bone destruction. So it's a continuous process of formation and then resorption. So it's typically equal rates of formation and resorption until we reach about 35 years of age. And then the process of bone resorption, which also equals destruction, actually is more. So at the age of 35, bone resorption or destruction increases. So that automatically decreases our bone mass. That happens to everyone just because of age. That's the physiological effects of aging. This predisposes a patient to injury, especially women. So essentially, osteoporosis is a metabolic bone disorder in which bone loss causes decreased density and possible fractures. This can happen, essentially, like I said, just from the natural process of aging. Some people are more at risk than others. We will talk about that in the next few slides. The list you see here are some specific assessment tests and diagnostic tests to assess the function and state of the musculoskeletal system. These are all listed in your book in the chapters identified for osteoporosis and Paget's disease. Most of the testing is imaging assessments. There are conventional x-rays of the spine and long bones that can show decreased bone density, but only after 25 to 40% bone loss has occurred. Of course, we can see fractures on a conventional x-ray. The most commonly used screening and diagnostic tool for measuring bone density is something called a dual x-ray, which is also known as a DEXA scan. The spine and hip are most often assessed with the DEXA scan. DEXA scan is actually very painless. It emits less radiation than a chest x-ray. It is the best tool currently available for the definitive diagnosis of osteoporosis. So this is the best tool that we have to absolutely definitively diagnose osteoporosis. Some other diagnostic testing listed here, of course, calcium and vitamin D levels. We know that calcium is associated with bone formation. Vitamin D is also required to help the bones absorb the calcium. It's very common for vitamin D deficiencies, especially in areas such as ours where there's not a lot of sunlight year-round. So that can be a factor in a patient who develops osteoporosis. It's important to know your typical, your normal serum calcium levels. Listed in your book is a level 9 to 10 is the normal calcium level. It's actually listed as 9 to 10.5. So it's important to know the normal levels for calcium for a patient in order to determine whether they're at risk for developing osteoporosis. Uric acid is actually, you're going to talk about that more when we talk about gout, but that's another blood test that helps us assess the musculoskeletal system. Radiography, of course, is x-rays, and then arthrocentesis is aspiration of fluid from a joint, and we'll talk about that more when we talk about osteoarthritis and rheumatoid arthritis. The same thing with the anti-nuclear antibody. We'll talk about that more when we talk about inflammation associated with arthritis. Again, this is a definition for osteoporosis. It's essentially a chronic metabolic disease of bone loss, which causes a decreased density, and it weakens the bone. It is often referred to as a silent disease because the first sign of osteoporosis in most people follows some kind of a fracture. Typically, we just don't know it. It doesn't really cause pain or anything. When your bone is weak, you really don't have pain from this until maybe a fracture occurs due to the weakness of the bone. That's why that DEXA scan that we talked about in the last slide, typically most providers will recommend that women get a DEXA scan at the age of 40 to get a baseline, so that we can then do every couple of years we can do another DEXA scan to determine whether they are not losing their bone density. Osteoporosis is in fact a major health problem in the United States and around the world, really. Estimated cost for care of a patient with osteoporosis in the United States is $18 billion each year. So it's important that we educate our patients about the risk factors for osteoporosis, and that we can identify if they are showing signs of osteoporosis and treat them appropriately early. You're going to find that throughout the course, our goal in a lot of these disease processes is to identify them early and treat them early. And if we can do that, the outcomes are better for the patient. So a lot of patient education is involved. Again, just talking about the bone, it's a dynamic tissue with a constantly undergoing the process of formation and destruction. And until about the age of 30 to 35, the cycle of formation and destruction is equal. After the age of 35, the destruction takes over, and there's far more destruction than there is formation. So that's what causes people to develop osteoporosis. Women are at higher risk. The reason women are at higher risk to develop this is about estrogen. When women become postmenopausal, They have less number of estrogen, and estrogen in their younger years helps to prevent bone loss. Estrogen doesn't build bone, but it's just when it's there in higher numbers, it is able to prevent bone loss. So that is why postmenopausal women are at high risk for developing osteoporosis. So if we ask what are risk factors, number one, women, especially postmenopausal women, are at higher risk. We also know that age 35 puts you at more risk. So they do kind of separate osteoporosis into primary and secondary causes. Primary osteoporosis is caused by a combination of genetic, lifestyle, and environmental factors. There's a great table in your book that lists the risk factors for primary osteoporosis. Those are things like age, gender. Women, of course, like I said, are a little bit more at risk. Family history of osteoporosis, especially in a mother. History of trauma after the age of 50, so trauma to the bone can cause a development of osteoporosis. Low body weight and thin build. Small postmenopausal women are at high risk. Smoking is a risk factor in about everything. High alcohol intake and lack of physical activity. Those are primary causes. Secondary causes are typically due to some other disease process that the patient has. Those are listed in your book as well. Disease conditions such as diabetes, thyroid problems, parathyroid problems. We'll learn when we talk about the endocrine system that the thyroid and the parathyroid work together to regulate the calcium levels in a patient. Bone cancer, HIV/AIDS are secondary causes of just some secondary causes of osteoporosis. And like I said, it's typically secondary means that it's due to another disease process or sometimes medications that the patient takes. Steroids is a very common cause of secondary osteoporosis. People who are on long-term steroids for a chronic condition, it puts them at risk for osteoporosis. So make sure you review these tables in your book. They're really good that kind of summarize these different risk factors for osteoporosis. So these are just some pictures to kind of help you to understand what a bone with osteoporosis would look like when we talk about that it becomes weak and loses its density. As you can see in this picture here of how spongy it looks. That's kind of how a lot of people identify it. It looks very spongy. You can see how here it looks way stronger. That's a normal bone. This is an osteoporosis. The other thing that occurs in a patient with osteoporosis is the loss of their height. That's why we typically, as people get older, we will always measure them when we assess their musculoskeletal system and keep record of that. As somebody loses inches, we know that it's typically related to having osteoporosis. Causes of osteoporosis or the effects of osteoporosis can cause a loss of as much as 6 inches in height. So it's just a way that we assess them. If they're losing height, then we are maybe going to do further testing as far as whether they have osteoporosis or not, and that will help guide treatment. So as nurses, we have to think about how to work with the patient as far as osteoporosis and what that means to us for nursing care. We need to know how to take a health history. So think about what that means. If they're a woman aged 35 and older, if they have a family history of, especially in their mother, of having osteoporosis, we are going to know that that's going to put them higher risk. Assessing them, if they're losing inches in height, that's another indicator that they could possibly have osteoporosis. Labs, think about the labs that you would look at. We talked about vitamin D and calcium. If those levels are low, we're going to be more concerned that they have osteoporosis. Imaging, again, then we would go to possibly just the conventional x-ray just to see it. But remember, you cannot see osteoporosis on an x-ray, on a conventional x-ray, unless they've already have 25 to 40% bone loss. We want to catch it early and we want to treat it early. So we might go ahead and if they fit all these risk factors, so if it's a 40-year-old woman whose mother has a history of osteoporosis, maybe their calcium levels are low on their labs, we're going to do a DEXA scan to see exactly what is going on in their bone. And then we hopefully, if it does look like there is some osteoporosis forming, we're going to go ahead and get them treated. Focus of osteoporosis prevention is to decrease modifiable risk factors. You're going to hear that a lot. Modifiable things. What are things that we can modify? What are things that we can't? So this 40-year-old woman that we were just talking about, she's 40 years old, not modifiable. We can't change that. Has a family history. Can't change that. That is non-modifiable. Fact that she's a woman, the gender, non-modifiable. There are things that we can modify. Those risk factors that are modifiable, such as smoking, such as alcohol intake, dietary intake. So we need to teach our patients about their diet as far as calcium, high levels of calcium, and think about what foods those are. Do you know what foods are high in calcium? Do you know what foods that you could recommend to your patient who needs to have a higher calcium intake? Think about what those are. Typically, it's dairy products, dark green leafy vegetables. Always dark green leafy vegetables are typically your answer to a lot of dietary issues. Vitamin D intake is also important. It's recommended, actually the Osteoporosis Foundation recommends that most adults take a supplemental vitamin D because most people have a bit of a vitamin D deficiency. Also, some other dietary things, make sure you research this for osteoporosis because most of these disease processes, what the nurse needs to know is how to teach a patient to modify those modifiable risk factors. So limit their amount of carbonated beverages. If they have a sedentary lifestyle, tell them we need to get up and start moving around. Even if it's just walking, some weight-bearing exercises helps to strengthen your bones. So if they had a choice between swimming and walking, swimming is always good. I will never tell anybody not to swim, but they also need to make sure that they're doing some weight-bearing exercises such as walking. That is helpful to strengthen the bone. When it's determined that a patient is at very high risk for osteoporosis or is already developing osteoporosis, we do have medications to treat those conditions. It's important that the nurse is familiar with the medication so that we can help educate our patients on how to take them and what to look for and what to report. And what to monitor for and the conditions that they should report right away. Supplements are, of course, calcium. With vitamin D, typically we recommend that they take a calcium supplement that has vitamin D with it as well because they just work better together. Calcium supplements, it's recommended that a third of the daily dose is taken at night. And if they don't take it at night, they're still going to get calcium. But if they take some of the dose at night, it's found that the calcium is more readily utilized by the body when the patient is fasting and not moving or immobile. So it just seems to be more effective if they take a third of the dose at night. Increase fluid to make sure that high levels of calcium in some patients can cause kidney stones. So if they have a good fluid intake, that should prevent that from happening. Biophosphates are medications utilized to treat patients with osteoporosis who have already begun to develop osteoporosis. These medications have some side effects and have some possible complications. So instructions for taking biophosphonates is important. It's important that the patients are educated well. These are listed in your book. Drugs listed under the bisphosphonates classification include Fosamax, or alendronate is the generic name. Basically, they prevent bone loss and increases bone density. They do this by slowing that bone destruction. So they're not just a supplement, they actually slow down the bone destruction or resorption to prevent osteoporosis. They are the most common drugs used for osteoporosis. Instructions, make sure you read in your book. Bisphosphonates. There's a lot of nursing safety priority drug alerts in your book about these drugs, because basically the patient has to take them in the morning. They have to take it on an empty stomach, take it with 8 ounces of water, and they have to sit up in an upright position for 30 to 60 minutes, and they cannot eat for 36 to 60 minutes. Basically why this happens is it can cause esophageal irritation. So they just have to be very careful that they do take it on an empty stomach first thing in the morning. Make sure they sit up for at least 30 to 60 minutes in an upright position, and drink it with at least 8 ounces of water. If they develop any kind of problem swallowing or esophageal problems, they need to report that right away. So nursing care of a patient with osteoporosis. So basically, what does this mean to us as nurses, all this stuff about osteoporosis? Well, we need to talk to our patient about safety. So if we have identified that a patient has osteoporosis, it means their bones are weak. So if they fall, they're going to break easier. And we know that the older a patient is, the more destructive a fall can be to them. So basically, teach them things to prevent injury, to not fall, making sure, educating them about their medications. We kind of talked about that. Help them to take it so that they'll take it correctly and that they'll be compliant with their medications. Nutrition, education about nutrition. We talked about that. So calcium, high calcium supplemental foods, green leafy vegetables, dairy, if they can tolerate dairy, things like that. Lifestyle changes. Think about what that means. Lifestyle changes. They should quit smoking. If they smoke, they should decrease their alcohol intake. Activity is very important. Exercise is important in the prevention and management of osteoporosis. It can also play a role in pain management, cardiovascular function, and basically just a sense of well-being. We always encourage some type of exercise in all patients, because it is really effective in preventing and treating a lot of disorders that we'll talk about throughout this course. It's important that they collaborate with a healthcare provider to make sure that they're doing safe, because again, remember, we don't want them to fall, so we want them to do activity, but we want them to do a safe activity for them. Encourage range of motion exercises to keep their joints mobile. That just kind of helps the blood flow. Always good for everybody. We'll do some case studies in class to identify patients that are at risk for osteoporosis, and then we'll look at how we would diagnose them, and then the nursing care involved in a patient with osteoporosis. Paget's disease is another chronic metabolic disorder. It's similar to osteoporosis. However, it is excessive breaking down and reformation of the bone. So it's kind of an unorganized formation and destruction of the bone. In contrast to osteoporosis, you know how we talked about in most people, there's a nice cycle of formation and destruction of the bone that's very equal until the age of 35. In Paget's disease, this is a chronic, unorganized of excessive breakdown and excessive formation. And the result of this is the bone itself is disorganized, and so it causes a weak bone because it just doesn't develop normally. It causes the bones to be weak, and they're at risk for like the long bones, and I have some pictures of this too. Long bones being bowed, and then they're at risk for fracture. There's two types of Paget's disease that can occur, familial and sporadic. So a couple of different things that kind of sets Paget's disease apart from osteoporosis is the fact that it is seen more frequently in people of ages 50 or older, so it's a little bit older. And then men are affected more than women. It is thought to be genetic in origin, so just think about that in assessing a patient, as far as health history. Asking them about their family history is always important. Whatever mom, dad, sister, brother have could put a patient at risk for having the same thing. These are the pictures of what a patient with Paget's disease will look like as opposed to a patient with normal bone structure here. You can see where the leg is bowed out here. The bone is weak and it breaks easily due to Paget's disease. Most patients with Paget's disease are asymptomatic until, again, like a bone breaks or it's accidentally found on an x-ray. Patients with Paget's disease will complain more of bone pain. There's a key features of Paget's disease. There's a table in your book, or it's actually a chart that has a key feature, and it talks about bone and joint pain, low back pain, bowing of the long bones, pathologic fractures. Pathologic fractures means that the bone just breaks, that there's no trauma needed. Sometimes they'll just like turn or something and it'll break a bone. So pathologic fractures always puts up the radar for a provider that, oh, we better look and see what's going on with this bone that is just breaking without a trauma. So there's a lot more pain involved in Paget's disease as opposed to osteoporosis. So this is part of our good assessment skills. So if we look at a patient who's complaining of bone pain and we look at them and do our assessment as far as musculoskeletal wise, we see bone, maybe a long bone that looks like it's bowed a little bit more than normal. Those are the kind of things that you're looking for in a patient to identify whether they might have Paget's disease. And then, of course, you're thinking about those other risk factors, such as men are more at risk and over the age of 50. Performing a musculoskeletal assessment in a patient with Paget's disease, pay particular attention to the size and shape of the skull. They could have actual enlarged, more thick skull. It sounds kind of funny because they just have a thick skull, so just make sure you're on the lookout for that as well. They can also have changes in their vision, hearing, and speech due to that thickened skull, because it can cause some brain problems as well, such as dizziness and things like that. So these are just some different things that we can do to diagnose a patient. Again, looking at their, just doing your assessment of their posture, their stance, and their gait. If they're complaining of pain, if they have a pathologic fracture. Calcium levels are a little bit less predictable in a patient with Paget's disease. Calcium levels can actually, it can be either low, normal, or elevated. And that's due to, remember, we talked about in a patient with Paget's disease, they have this it's really not about calcium deficiency in them. It's more of a genetic disorder as far as the formation and destruction of the bone. So it doesn't have as much to do with their calcium levels. Because we talked about osteoporosis can develop when a patient has low calcium intake. Paget's disease, it's not affected by your calcium levels. It's more because it's genetic. So it often so the calcium levels are a little bit less predictable in a patient with Paget's disease. Of course, we can X-ray a patient to look at their deformities of their bone. I didn't list it here, but CT and MRI can also be used to help diagnose more definitively bone disorders. Just make sure you're familiar with what a CT is. It's a CAT scan. It's an X-ray, but it has high levels of radiation as far as a CAT scan. So it's high. And you can see the picture better on a CT scan than you can an X-ray. So it kind of goes in the order of if we see something abnormal on a basic conventional X-ray, that we suspect is something, then the patient will most likely be sent for a CT scan because it can give us a better picture, a more clear picture, because it's using more radiation. MRI is used. It can also give us a really good picture. There's no radiation involved in an MRI. It is actually magnetic. It's a magnetic resonance imaging. So they're both very, very almost used interchangeably. Sometimes if we can't see it definitively on a CT scan, we'll also do an MRI. It's important to begin to understand as a nurse how you prep someone for these procedures. CT scan is radiation, so anybody who is thought to be pregnant cannot have a CT scan. They would have to have an MRI. MRI is magnetic, so anybody that has any kind of metal plate, any kind of implant that is not MRI compatible, things like that, we're going to need to, or they can't have an MRI. So there's for a CT and MRI, there are some questions involved prior to doing those tests to make sure that it's safe for them to have those tests. X-rays are pretty safe. Of course, a woman that is suspected to be pregnant cannot have an X-ray due to the radiation. So make sure you review that in the prep for a patient undergoing some of these tests. What we need to do as nurses, questions that need to be asked. And the X-ray, CT scan, MRI are both non-painful. The only thing about the CT and the MRI is the fact that you have to lay still. An MRI makes a lot of noise, and you're kind of in a tube. And we'll talk about this more throughout the course about how to prep somebody for an MRI. But MRI, a lot of people have difficulty doing that test, especially if they're claustrophobic, because they put you in a tube and it's really loud and it kind of freaks some people out. So just some things to think about. Treatment for Paget's disease. The oral biophosphonates are the first line of treatment. And if you think about this, the biophosphonates are used to decrease the amount of bone destruction. So that's why these are used as first-line treatment for a patient with Paget's disease. So a patient with Paget's disease more likely to be medicated with medications such as the biophosphonates. Also, nonsteroidal anti-inflammatory medications such as ibuprofen are used for the pain, because remember, they're more likely to have pain with their disorder. So it's important to remember that a patient with Paget's disease has more of a chronic metabolic disorder associated with genetics. So labs, and there's going to be a little bit more monitoring of their labs to kind of find out where their calcium level is, kind of pay more attention to that. There's some other labs listed in your book that can help to monitor a patient with Paget's disease. Serum alkaline phosphatase can identify for the provider if about the level of density to the bone. Elevated bone isoenzymes can it just helps with more of a definitive diagnosis of Paget's disease. So just really what you need to know as the nurse is that a patient with Paget's disease is a little more complex. And so there's a little bit more monitoring involved, and they are more likely going to be on more medications than a patient with osteoporosis. They still have weak bone, and they're at risk for fractures, and they have pain. So those are some concepts that we need to think about for these patients: safety, mobility, and pain management. So just looking at a few questions here covering the content that we just talked about. Which statement best validates an older patient's understanding of musculoskeletal health and interventions? So what do we know here? We know that we're talking about an older patient, and we're looking for the statement that best validates an older person's understanding of what they should do as far as interventions. Interventions mean things that they can do to prevent a problem. So looking at A, I should use a cane when I walk. Well, yeah, we're not really sure. not every older person has to use a cane when they walk. It can prevent some people from falling, but what we know about this patient is just that it's an older patient. They just want to talk about musculoskeletal health interventions. I should drink 8 ounces of orange juice daily. Well, let's think about that. Orange juice. Why would they have to drink orange juice? Well, there are some orange juices that are high in calcium. Do we know if this particular orange juice is high in calcium? Not necessarily. Let's move on to the next one. I should try to exercise at least 5 times a week. Well, what do we know about exercise as far as the musculoskeletal system? We know that it can strengthen the bone and promote bone stability. It can do a lot of other things for the body as well. Cardiovascular system, joint mobility, a sense of well-being, things like that. I kind of like that one. 5 times a week, of course. Now, it doesn't say what kind of exercise, so it's pretty general about that. It could be walking. It could be, walking small amounts, things like that. So, and then D, I should ignore my pain and adapt to moving more slowly. Well, we should never ignore pain. That's your body trying to tell you something. So, my money is on C, just based on what we know, and that is a correct answer actually. And the reason that is just because, again, like I said, exercise promotes bone stability and bone strength and can prevent the development and progression of osteoporosis. Next question. The nurse knows that a patient with Paget's disease is at greatest risk for developing which complication? Okay, looking at this question, the nurse knows that a patient with Paget's disease is at greatest risk for developing, is it kidney stones? Well, we know kidney stones is related to high calcium levels sometimes, so in some patients. Is it really related to Paget's disease? It could be Paget's disease or osteoporosis or just anybody with a high calcium level. Cardiac failure, there's really no great link between cardiac failure and Paget's disease. Chronic fatigue syndrome, it can cause some fatigue due to the pain and difficulty with mobility, but is that the best answer? Pathologic bone fractures means that the bone might spontaneously break due to weakness in the bone. We know that can happen in a patient with Paget's disease. A lot of times that's how they're diagnosed. So it can be D, pathologic bone fracture. That's the best answer in this case. The femur and the tibia are most often affected with pathologic bone fracture in a patient with Paget's disease. Patients with Paget's disease frequently are fatigued. Although less common, they can develop kidney stones and heart failure, but the highest incidence, again, is letter D, and that's the best answer. Okay, looking at a question about aldronate, that one's hard to say, but it's also known as Fosamax. We know that this is a biphosphonate, and a lot of the biphosphonates will end in NATE, so that's kind of helpful for us. So aldronate is prescribed for a patient with osteoporosis. The nurse is providing instruction on administration of the medication. Which instruction should the nurse provide? Well, let's look at these answers. A is take the medication at bedtime. Well, from what I read about it, it's actually supposed to be taken early in the morning before eating. Take the medication in the morning with breakfast. That's not what I read about it. What I read is that it's supposed to be taken on an empty stomach prior to breakfast. Lie down for 30 minutes after taking the medication. Well, remember what we read about it, and what I talked about is that they're supposed to actually stay upright for 30 to 60 minutes after taking the medication due to the risk for gastroesophageal irritation. The last answer is take the medication with a full glass of water after rising. I believe that is what we read about it, that you should take it with a full glass of water in the morning on an empty stomach. Precautions need to be taken with the administration of this medication to prevent gastrointestinal side effects and to increase absorption of the medication. It needs to be taken with a full glass of water Clients should not eat or drink anything for 30 minutes following the administration, and they should not lie down after taking it. So again, here, D is the correct answer. This concludes this presentation for osteoporosis and Paget's disease for Nursing 150. I look forward to discussing these topics more with you in class.